Hello, my name is Andreina Tarff. I am an internal medicine doctor, PGY2 at Weiss Memorial Hospital, Chicago. I'm going to present a case. This is a 31-year-old woman presenting with abdominal pain and distension that turned out as portal and splenic vein thrombosis with bilateral pulmonary thromboembolism and previous pulmonary infarction. Our patient presented to the ED complaining of progressive abdominal pain associated with constipation, bloating, and nausea for more than 3 weeks. Patient also gave history of a slightly tightness sensation in the lower chest that radiated to the back when taking deep breath. I must mention that the chief complaint of abdominal pain is a common presenting problem with such broad differential that often possess diagnostic and therapeutic dilemmas. That's the reason a detailed history remains the single best discriminator to determine acuity, etiology, and best initial management. At first, our patient denied any known medical condition. The patient denied any significant family history. On physical examination, patient was hemodynamically stable, abdomen soft, mild distension and tenderness in the middle and bilateral abdominal upper quadrants, normal bowel sounds, no palpable masses. Initial labs show platelets 761, PT 11.9, AST, LAT slightly elevated, CBC, rest of CMP, troponin unremarkable, and AKG within normal limits. CT abdomen and pelvis with IV contrast reveal a splenic vein thrombosis at the ileum, thrombosis of the right portal vein and its branches, thrombosis of some of the branches of the left portal vein, fullness in bilateral annexa with 3.2 cm low density lesion in the right annexa, possible cyst. CT angio of the chest, as we can see in our image, reveal non-occlusive bilateral pulmonary emboli within the pulmonary artery at the left lower lobe with a small area of scarring at the pleural surface, likely secondary to prior pulmonary infarction, as we can see the Hampton hum on the left lung. Also, bilateral lower extremity duplex was within normal limits, and after discussing the results with the patient, she disclosed history of deep vein thrombosis 4 years ago, followed by pulmonary embolism, and also she disclosed wins on rivaroxaban and aspirin in the past. Our initial management and workup include therapeutic dose of enoxaparin, multidisciplinary management, factor V laden prothrombin gene mutation homocysteine, antiphospholipid workup for thrombocytosis evaluation, and only anticardiolipin IgG was 13, slightly elevated. Further investigation revealed that in the past, this antibody was slightly elevated in the past as well. And we can conclude from this case that antiphospholipid syndrome is an increasingly considered to be multi-organ and multi-system disease with expanding spectrum of clinical manifestations that may involve different organ systems. Specifically, the anticardiolipin antibody increase and decrease under certain conditions such infections. Positive results should always be confirmed after 8 to 12 weeks. However, consistency of low titers as seen in these patients may be associated with a higher risk of thrombotic events overall. And we can also conclude that antiphospholipid syndrome-related gastrointestinal manifestations are diverse, complex, non-specific, and easily confused with other abdominal diseases, which leads to misdiagnosis, and therefore this report provides useful information to achieve early diagnosis, early management plans according to relevant literature and guidelines.